abdominal wall and hernias. I want to discuss for you the abdominal wall. Abdominal wall is is a complex structure composed of primarily of muscles, bones, and fascia. The major function of the abdominal wall is to protect the organs, intra-abdominal organs, and the urogenital tract. But it has another function, which is the mobility, which flex, extend, rotate, and vary its capacity in order to take the contents of the abdomen. Flexibility of the abdominal wall usually requires elasticity and muscle stretch, which compromise the abdominal wall strength. If you look to this photo, you will see that the abdominal wall is composed of three major muscles, which is the external oblique and the rectus abdominis muscles. Below it is the internal oblique and the transversus abdominis muscles. This is the linea alba, umbilicus. And to this area is the groin area, which is the inguinal area. If you look to this picture, you will see that there is two weak areas. If you concentrate on this, which is the posterior triangles and the groin area, there are small defects in this anatomical defects into these areas, which are responsible for the development mainly of hernias, which we will discuss later on. If you see this is the muscles of the abdominal wall, anterior wall, layer of rectus sheath, and all the muscles are seen here. I hope you will see it well. The roof of the abdomen, the roof is formed by the diaphragm. So the abdominal cavity starts from the diaphragm, which separates the thoracic cavity above, which have a negative pressure, from the abdomen below, which has a positive pressure. So any defect in the diaphragm will lead to herniation of the intra-abdominal organs from the positive pressure area to inside the chest, which is the negative pressure area. Weakness of the diaphragm can lead to, as I discussed, so the bony pelvis forms the floor of the cavity, but there is a muscular central portion and the perineum, which may be weakened and allow the rectum, bladder, and gynecological organs to bulge downward, a condition which is called a prolapse, which is also a type of hernia. Posteriorly, the muscles are strong. The muscles that cover the posterior abdominal wall are strong, further supported by the vertebral column, ribs, and pelvic bones. Two regions called the posterior triangles, which are weak areas and can lead to rare lumbar hernias. So these two areas are weak areas which can lead to lumbar hernias. Laterally, there are three thin muscle layers whose fibers crisscross for strength and flexibility, and the surgeons can get benefit from these cross-crossing fibers to increase the girth and allow closure of defects in the center of the abdomen. Anteriorly, the two powerful rectus abdominis muscles extend vertically from ribs to pelvis, anterior abdominal wall muscles. Herniation through these strong muscles does not occur naturally unless in the area of the linea alba, which is the central joint area weakness resulting in epigastric and paraumbilical hernia. So normally the hernia does not occur through the strong muscles, but in the weak areas. These weak areas are present naturally in the anterior abdominal wall and posteriorly laterally. Divarication of the recti is the condition where the linea alba stretches laterally as the two rectus muscle separates. If you see the muscles, the linea alba, it may stretch laterally and to the two rectus muscles separate. This condition is called divarication of the recti, and it is a type of hernia. It usually occurs in middle-aged, overweight men, but also can occur in the pregnancy or birth trauma in female when it occurs below the If you see the photo, this is the umbilicus. There is a small para-umbilical hernia, and the bulging here in the epigastric region, in the area of the midline, which is the area of the linea alba, it is called divarication of the recti. Inguinal hernia is the most common hernia because the muscular anatomy of the inguinal region is weak, while the incisional hernia, site of previous surgery, is next to inguinal hernia in occurrence. If you see this picture, you see that inguinal is the most common, and then second is the incisional, site of previous incision, third is the femoral, fourth is the epigastric, and umbilical. Here is the umbilical obturator hernia. If you see obturator hernia. Number 7 is Spigelian hernia. The Spigelian hernia. These are rare types of hernias, which obturator, Spigelian, lumbar and gluteal lumbar hernia in the posterior triangle, as we discussed. And here is the gluteal region. These are the size. Anatomical causes of abdominal wall hernia. Despite the complexity of the design of the anterior abdominal wall, the only natural weakness caused by inadequate muscular strength are the lumbar triangles and the posterior wall of the inguinal canal. So these two areas are natural weak areas: posterior triangle, lumbar triangles, and the posterior wall of the inguinal canal. Many structures pass into and out of the abdominal cavity, creating weakness which can lead to hernia formation. The most common example is the inguinal canal. You know that the testicles are undescended. During pregnancy, they are present near the kidneys, and then when they descend down from abdomen to scrotum, at the time of birth, there will be a defect will remain in the anterior abdominal wall in the deep inguinal ring, this and the posterior inguinal canal. This area is the site of the future development of hernia. Other examples, you know, the esophagus, when passed through the diaphragm, it may lead to hiatus hernia. Femoral vessels, when it leave the abdomen, enter the thigh, there will be femoral hernia in the femoral orifice. Obturator nerve lead to obturator hernia, and sciatic nerve leads to sciatic hernia. So these defects are present, they are weak areas, and they present and they are the site of previous development, future development, of the hernia. Failure of normal development may lead to weakness of the abdominal wall. Examples are diaphragmatic, umbilical, and epigastric hernias are later life. You know, surgical scar in any part of the abdomen, even with perfect good wound healing, has only 70% of the initial muscle strength. This loss of strength can result in herniation in at least 10% of surgical incisions, in spite of good closure. Sometimes sudden presence of a mass in the anterior abdominal wall in the rectus muscle may be a result of rectus sheath hematoma. Occasionally, this is due to trauma, but nowadays, more often due to excessive anticoagulation, patients on warfarin or patients on other anticoagulant drugs. Causes of hernia, as we discussed, basic design weakness. There is weakness in the anatomy of the abdominal wall. Weakness due to structures entering and leaving the abdomen. Developmental failures, for example, undescended testes. Genetic weakness of collagen. Some persons has genetic weakness of the collagen which formed part of the muscle. Sharp and blunt trauma. Weakness due to aging and pregnancy. For example, direct inguinal hernia is more common in old age persons. And weakness in the muscle during pregnancy. Primary neurological and muscle disease. Any muscle disease and neurological diseases that lead to weakness of the muscle may lead to development of the hernia. And lastly is the excessive intra-abdominal pressure. Anything inside the abdomen which lead to increase intra-abdominal pressure, which will we discuss later on. So the main etiology is straining and chronic constipation, habitual rectal stricture, anything that leads to straining during passing motion or during passing water. Lifting of heavy weight, chronic cough, TB, chronic bronchitis, bronchial asthma, COPD, and other diseases. Urinary causes, for example, in old age, benign prostatic hyperplasia, carcinoma of the prostate. Young age stricture, urethral stricture. Adulthood may be due to phimosis and meatal stenosis. Obesity may be one of the etiological factor of hernia. Pregnancy and pelvic anatomy, especially in femoral hernia in females. Smoking also lead to increased risk of one of the etiological factor of hernia, smoking, because it may lead to weakness of the muscle, deficiency in the collagen, and it lead to chronic cough. Ascites, which these are causes of increase intra-abdominal pressure. As we said, ascites, chronic constipation. Previous history of appendectomy through gridiron incision may lead to injury to the ilioinguinal nerve, causing right-sided direct inguinal hernia. Familial collagen disorder, which is prone belly syndrome. Pathophysiology of hernia, how hernia will form. A normal abdominal wall has sufficient strength to resist high abdominal pressure and prevent herniation or content. This is normally. But herniation has been attributed to high pressure. If there is high intra-abdominal pressure from constipation, prostatic symptoms, excessive coughing, respiratory disease, and obesity, these will lead to increase intra-abdominal pressure, and many patients will first notice a hernia after excessive straining. There is good evidence that hernia is a collagen disease and due to an inherited imbalance in the types of collagen. This supports the histological evidence and relationships between hernia and other diseases related to collagen disease, for example, aortic aneurysm. So, hernia development is more common in pregnancy due to hormonally induced laxity of the pelvic ligament. It is also more common in the elderly due to degenerative weakness of muscles and fibrous tissue. A recent Swedish report has shown that inguinal hernia is less common in obese patients, with hernia risk being negatively related to body mass index, contrary to what was believed. So, this report shows that the hernia risk is negatively related to body mass. Whenever the patient is obese, the risk of hernia is decreasing. This is a recent study, and hernia is more common in smokers. Common principles in abdominal hernia. Usually the abdominal wall hernia The hernia in general has two essential components, which is a defect present and a content. Defect and content. These are the two major. A defect that is present in the wall and contents that present in the cavity that containing that defect. So the weakness may be in the muscle, for example, incisional hernia, maybe in the fascia, for example, epigastric hernia, in the linea alba. It may have a bony component, for example, femoral hernia. One of the lateral border of the hernia is the bone. Any defect will lead to a femoral hernia. The size of this defect varies from very small size into very large size. Here I want to tell you, whenever the size of the defect is small, the risk of obstruction and strangulation is greater. Whenever the size is small, the risk of strangulation and obstruction will be more. Whenever the size is large, the risk will be less, because small defect, the rigid walls, traps the content and prevents it from freely moving in and out of the defect, increasing risk of complications. The content of the hernia may be fat, for example, epigastric hernia, may be the urinary bladder and direct inguinal hernia in old age male, maybe omentum, maybe part of the bowel. So with increasing time of the hernia, the patient, for how long the hernia has, the contents will increase. For example, it will start with fat, and then after omentum will enter, then after bowel will enter, and so on. In most cases, the intraperitoneal organs can move freely in and out of the hernia. This is called reducible hernia, when the contents can be reduced spontaneously or it will be reduced manually. So it means that there is no adhesion and the contents will move freely. In contrast, when the adhesions will develop and the contents will be unable to return to the main peritoneal cavity, this is called irreducible hernia, which has a high risk of complications. The narrowest part of the sac is called the neck of the sac. This is the neck of the sac. This is the sac. This is the contents, which the dilated bowels, bowel loops. This is the skin, this is abdominal wall, muscles, and this is the peritoneum. So at first this is the sac, which is the peritoneal fold. Consists of the diverticulum of peritoneum. This is diverticulum of the peritoneum, is the sac, and then the content, and then we have the coverings of the sac, which is the layers of the abdominal wall. Sometimes the hernia has no neck with large mouth, lock neck. For example, direct hernia has no neck because the mouth of the hernia of the sac is large, and incisional hernia without sac. For example, epigastric hernia, it is protrusion of extraperitoneal pad of fat. Coverings, as we discussed, that it is the abdominal wall coverings of the sac. Omentum, contents of the sac, maybe the omentum is called omentocele. Sometimes it's the intestine, which is enterocele, and mostly it is small bowel, but sometimes or even large bowel can be enter the hernia, and it is usually difficult to reduce the sac. Types of hernia. We have different classification modes to classify hernias. We have hernia by complexity. How the hernia is complex. Occult hernia, not detectable clinically, may cause severe pain. Clinically, when you examine the patient, he has no hernia, but only he has severe pain, but the hernia may be between the muscle layers and one example is the Spigelian hernia. Reducible hernia, which appears and disappears. Irreducible hernia, swelling which cannot be replaced. High risk of complication. Strangulated hernia, when there will be vascular compromise, there will be interference with the blood supply of the content of the hernia. For example, if the content is the small bowel, there will be interference with this vascular. It will lead to strangulation, and later on it will lead to infarction of the hernia, of the content, and may become gangrenous, and which has a high mortality rate. So every hernia will start as a reducible, then it will become irreducible, then it will strangulate, then it will infarct, and lastly it will lead to gangrene of the contents. Classification of hernia. Another classification is the clinical classification, which is reducible hernia, irreducible hernia, obstructed hernia, inflamed hernia, and then strangulated hernia. The other classification is the congenital, according to the timing of congenital hernia. Common, for example, occurs in preformed sac defect. It occurs in a preformed sac defect. Clinically may present at a later period due to any of the precipitating causes, like in indirect inguinal hernia. Indirect inguinal hernia, most of the hernias in infancy is indirect inguinal hernia. It's congenital. And other types is the gastroschisis, congenital defect in the wall of the abdomen. This is congenital. And true umbilical hernia. True umbilical hernia, true, is usually congenital. Before the age of 2 years, the hernia is congenital. Otherwise, it is umbilical. Otherwise, it is considered as a paraumbilical. Acquired hernia, it is due to increased etiologies that we discussed before. Classification of hernia. Classification number 3 is according to the contents. Omentocele, introcele, cystocele, maybe Meeker's diverticulum, which is called Litter's hernia, and Miles hernia, sliding hernia, Richter's hernia, part of the bowel. Classification 4, which is based on the sites. Inguinal hernia, femoral hernia, diaphragmatic hernia, obturator, Spigelian, and so on. Clinical history and diagnosis in hernia cases. Clinical history and diagnosis. Usually, patients are aware of a lump on the abdominal wall under the skin. It's usually self-diagnosis. The patient will diagnose his condition. And usually it is painless, but patient may complain of an aching or heavy feeling, something heavy in the, for example, groin or other part. Severe pain may alert the surgeon to a high risk of strangulation. So pain in hernia means strangulation. The hernia may reduce spontaneously or needs to be helped manually. The patient should be asked about symptoms which might suggest bowel obstruction, for example, vomiting, constipation, and so on. It is primary hernia, the occurrence after previous surgery, whether the hernia, and general questions about the patient's job, cough, and other things. When you examine the hernia, check for reducibility, cough impulse, tenderness, overlying skin color change, multiple defects, signs of previous repair, scrotal content for groin hernia, and associated pathologies. Examination. Swelling with cough impulse is not necessarily a hernia. Be aware that swelling with a positive cough impulse is not necessarily maybe hernia. It may be a vascular lesion. And another note is that swelling with no cough impulse may still be a hernia. Opposite. Vice versa. Investigations. Plain X-ray has no value. Ultrasound, low cost, operator dependent. CT may show incisional hernia, and CT scan also is helpful. Sometimes will show the hernias that are not detected clinically. MRI, good in sportsman's groin with pain, growing with pain, which if you, in order to differentiate whether he is sportman, he has a muscles tear, or maybe a bone avulsion, or it is a hernia. Laparoscopy nowadays is useful to identify occult contralateral inguinal hernias, and nowadays most of the surgeries can be done laparoscopically. Management principles for all hernias. Usually, abdominal hernia does not necessarily require repair, usually if it is symptomatic. So indications for surgery are abdominal wall hernia with symptoms of discomfort, or for cosmesis, or undoubt about diagnosis. You are unsure about diagnosis, so you have to explore. Complications are likely, the most being bowel strangulation and obstruction. If complication develop, this is indication for surgery. All cases of femoral hernia, because it has a high risk of strangulation because of the narrow neck. Any case of irreducible hernia, especially with pain, tenderness, unless the patient is unfit for GA. Increasing difficulty in reduction and increasing size are indications for surgery, and the surgery should be offered to younger adult patients as symptoms and complications are likely over time. In young patients, usually surgery is indicated because with increasing age, he will develop the complication later on. All surgical repairs follow the same basic principles. You have reduction of the hernia content into the abdominal cavity with removal of any non-viable tissue and bowel repair if necessary. Excision and closure of a peritoneal sac if present, or replacing it deep to the muscles. Number 3, reapproximation of the walls of the neck of the hernia if possible, and permanent reinforcement of the abdominal wall defect with sutures often. So mainly we have two types of surgery, which is herniotomy and herniorrhaphy. Herniotomy is the excision of the sac, and this is usually used in children, and herniotomy and herniorrhaphy, which is excision of the sac and reinforcement of the abdominal wall defect with nylon sutures or mesh. Characters of the mesh, we have many types of mesh. It is not important for you to know, but just to know that we have polypropylene mesh and mixed polypropylene and vicryl mesh. Lichter's hernia, portion of the circumference of the bowel is usually present. Cystocele, urinary bladder, may be the content of the sac, and often with fallopian tube. Litters hernia, sac contains the mucus diverticulum. Thank you very much, and hope for you a nice day.